Welcome to a new podcast episode of Radiology AI. My name is Dania Daye, and I'm the Associate Editor for Social Media for Radiology AI. And today, my co-host Paul Yi and I are very excited to bring a new episode of the Radiology AI podcast series. Today, we will be interviewing Dr. Carol Wu and Dr. Ian Pan, and we will be discussing the RSNA 2020 PE Detection AI Challenge. Dr. Wu and Dr. Pan, thank you for joining us today. First, I'll start with a few introductions. Dr. Wu is professor in the Department of Thoracic Imaging and Division of Diagnostic Imaging at the University of Texas MD Anderson Cancer Center. She completed her diagnostic radiology residency and cardiothoracic imaging fellowship at UCLA. She then worked as faculty at Massachusetts General Hospital for 6 years prior to joining the University of Texas MD Anderson Cancer Center in 2014. She's currently involved in AI informatic work nationally, including with the Society of Thoracic Radiology STR, where she is the chair of the Big Data Committee in the RSNA, where she recently led the annotation effort of the 2020 RSNA Pulmonary Embolism Detection AI Challenge. Dr. Ian Pan is currently resident in radiology at Brigham and Women's Hospital. His passion is at the intersection of machine learning, data science, and healthcare. Dr. Pan is a graduate of Brown University, where he majored in applied math. He then obtained his master's in biostatistics and most recently his MD in 2020. He has published extensively in the radiology literature, including in radiology and radiology AI, and has won several Kaggle data science competitions, and is in fact the first Kaggle physician grandmaster. Most recently, he finished his second place and received the 2020 Educational Merit Award for the RSNA PE AI Challenge. Carol and Ian, thank you for joining us today. I will turn it over to my co-host, Paul, for the interview.
It's a pleasure to have you both on the podcast, Carol and Ian, to talk about the RSNA 2020 PE Detection AI Challenge. I like to start each episode off by learning more about our guests. Carol, can you tell us a little bit about yourself and how you got involved with informatics and AI?
Sure. I want to first thank you for inviting me for this podcast. So I'm a chest radiologist. I spend about 60 to 70% of my time doing clinical work, reading chest radiographs, chest CTs, and PET CT. And maybe a little bit something different about me is that I was a biology major in college. I did not study computer science or engineering, but I think, it's a point I want to get across to people that it is possible to be involved with informatics and AI without coming from an engineering or computer science program. So if other radiologists are interested in doing this type of work, they should volunteer. We can always use help from people with clinical expertise as well. I got involved in informatics and AI because of my research interest in incidental findings. When I started off as an attending radiologist at MGH, and that's when I realized that informatics tools are very helpful in advancing my research interest. Then I also took an RSNA sponsored course on value of imaging through comparative effectiveness program, which included some training on big data type research. And that's how I started becoming involved when the Society of Thoracic Radiology started a big data committee.
Thanks so much for sharing your background, Carol. I think it's a really great point that informatics and AI, we can come at it from different perspectives and different backgrounds, whether you studied computer science in college or didn't at all. Speaking of people who studied computer science in college, Ian, we've interviewed you before on the podcast, so our listeners know a little bit about you already. But when we last talked, you were an intern, and now you're a brand new radiology resident. So can you update us on what's been going on since then? How does it feel to be in radiology?
Yeah, so I think it was more than 6 months ago that you interviewed me. So I was like in the middle of intern year, It was pretty tough because of COVID back then. But since then, I've gotten like a lot more comfortable being an intern. I felt like I was really getting into the rhythm of things. And then the year ended and I started radiology residency where, I don't know, it's kind of like going back to medical school almost because you don't really know much about anything. And coming from intern year, where you start to become pretty much like an expert at what you were doing, like all the intern tasks and stuff, and then going to like bottom of the totem pole again, definitely an adjustment that I have not totally gotten used to yet. It'll probably take me some time. But it's been really fascinating just like seeing how much there is that I have to learn. And I think, one thing that I tweeted about after my first week of radiology residency was I didn't think there was any way AI was going to replace us anytime soon, just given the complexity I was seeing just within that first week and the amount of knowledge that you have to have and the amount of dialogue there is with ordering providers, et cetera. So I'm pretty excited to learn more about radiology. Still kind of nervous about going into the reading room every day because I'm probably going to look like an idiot, but I think it's all part of the process.
Yeah, I wouldn't be too worried, Ian. I think most of us felt this way during our first and even during our second and maybe even our third years of residency. I think that's a really good point that you make, that it's pretty complex to be a radiologist. It's not just looking at images and detecting features and finding patterns. And to Carol's point, I think that there's definitely a role for radiologists who may not have any coding background or experience with AI per se, just because we need subject matter experts to annotate images to make sure that we're answering clinically important problems. And so speaking of clinically important problems, the topic of today's podcast is the 2020 RSNA PE AI Challenge, which was held last year. And like the 2019 challenge, this was a huge multi-institutional effort to facilitate AI research solutions for a very clinically relevant problem. Carol, you were involved with a lot of the annotation process. Can you tell us the story of the challenge and how it got started?
Yes, we first started discussing using pulmonary embolism detection as a possible topic for the challenge when we had the RSNA meeting in 2019. And just as you mentioned, it's important to identify a clinically important question. And we all felt that PE is very important. It's a diagnosis of urgency. It does have tremendous impact on patient care. The other consideration we had was that we have to be able to obtain enough data. And we all know that CT pulmonary angiography is used very widely all over the world to diagnose PE. So we know that we would be able to find a large volume of cases. And finally, because we, RSNA had collaborated with Society of Thoracic Radiology in the past with the pneumonia challenge, that we know that in picking a chest topic that we would be able to recruit and identify subject matter experts to help us. So those were the main considerations that got us started on this topic.
Yeah, and the data set for this challenge was actually the most complex that the RSNA had put together yet. If I recall correctly, it had over 2 million individual CT images originating from multiple countries, along with numerous annotations beyond the mere presence or absence of clot, but extending into location, to chronicity, and even associated anatomical features like the ratio between the right and left ventricles. Can you give us an overview of the dataset assembly and annotation process? How long did it take, and what challenges did you face along the way?
Yes, I think from the time we started planning at in December 2019 until the time that we actually posted the data set on Kaggle, which was September 2020, it take quite a bit of time. And all throughout the process, we were under a lot of time pressure. But in general, like all of the challenges, we want to secure the data. So we talk to people we know for solicitation, and then they have to go to their institution to get IRB approval and to have legal document signed to allow the data to be made public. Then there's the whole process of identifying the correct cases, the de-identification of material, and then sort of simultaneously, we were trying to design the annotation process, what exactly we want to have the annotator do, and what is a reasonable amount of work to expect from our annotator, and just to design the whole platform so that it's user-friendly and will maximize inter-reader agreement. And then from there, we had to also train our annotator, and then just encourage everybody to continue to annotate. And then after that, we had to do some QA and adjudication. But basically, all the details are listed in the paper that we have published in the Radiology Artificial Intelligence journal. It was a lot of work from a lot of volunteers, both in the data contribution and also in the annotation and the whole organization. And I'm so glad to have worked with such experienced team. We have worked together on other radiology AI challenges. So we were able to tackle this big project efficiently.
Yeah, it definitely was a huge undertaking. I think that the radiology AI community has benefited tremendously from it. One thing that I'm curious, maybe from both you, Carol, and Ian, is your take on the ground truth. So as we know, ground truth for AI studies is really important to ensure that data labels are accurate. But as you noted, Carol, it can be difficult to establish, partly due to the time and expertise that requires from radiologists. Ian, I think you're starting to get a sense of just how much training and time it can take just to go through one study. And so for the data set in this challenge, training images were read by a single annotator, while the test images were triple read, i.e. by 3 annotators. Can you talk about the reasoning behind this decision? And maybe for Ian, how does this impact your approach towards tackling a challenge like this, if at all?
So the reason that the training set was only annotated by a single annotator is because we simply do not have the manpower to double or triple annotate the training data set. But we did actually run some QA on the training data, and some of the cases were selected to be adjudicated so that they were actually looked at by more than one radiologist, sometimes 2 or 3. And then for this particular AI challenge and also the pneumonia challenge, we wanted to have more than one annotator for the test set because we want to make sure that the ground truth is well established by experts. So surprisingly, when I initially started the process, I thought it's easy for everybody to agree on the read of pulmonary embolism because it's on CT and it's not chest radiograph. The findings should be pretty clear and there should be no disagreement. But surprisingly, there were some cases that were actually quite difficult and they were disagreements. So I am very happy that we did have more than one readers and that we adjudicated those cases to make sure that we have a well agreed upon ground truth. And like you know, for PE diagnosis, there's no pathology. So whatever we say as radiologists is taken as the ground truth. So I think it's important that we have more than one expert looking at the case and make sure that we have some kind of agreement.
Yeah, definitely. I think I remember many a call night when I have to call up one of my colleagues or ask someone, "Hey, do you think this is real?" Because as you know, there can be a lot of artifacts. Sometimes it's not clear if it's a real PE or if it could
Yes.
be some type of artifact.
Right.
Ian, I'm curious, what's your take on this? Does this impact how you look at these challenges and how you think about a solution when you think about, maybe the standard of annotation differences there might be between training and testing sets?
Yeah, definitely. So with all of these challenges, one of the key things is to recognize when the distribution of the training set that's provided is different from the test set that the models are evaluated on. And ideally, as a competitor, you want it to be pretty similar, right? Because you perform a lot of experiments, and most of these experiments you will validate locally. So you'll do like cross validation on the training data or whatever. And if your training set is different from your test set, then the experiments and the results you're getting from those experiments on your local validation may not correspond to the same changes in performance on the public leaderboard or the private leaderboard. And so you have to figure out pretty early on if these distributions are similar or not, because that's going to inform your validation strategy. And then an added complexity of it is sometimes the public test set is not the same as the private test set, in which case the competition is pretty hard to predict what the final result is going to be, because you really have no way of knowing, how well your models are going to do if the final distribution is completely different from any data that you're allowed to actually see the results for. For this challenge, the fact that the training set was single annotated and the test set was triple annotated, it actually didn't influence what I did at all, because what I do is I will submit early on to see if my local validation is corresponding with the public leaderboard performance. So if I, do an experiment and I get this result, which is an improvement from another result on my local validation, I'll then submit both of those experiments to the leaderboard and see if it also resulted in an increase on the leaderboard. That makes me feel more confident that, whatever tweak I made is actually improving the model. And early on in this competition, I found that there was pretty good correlation. I will say that during the pneumonia detection challenge, that was not the case. And in that case, the training set and the test set had pretty different distributions. And one, I think, was the triple annotated test set. But not only that, those were annotated by subspecialty trained thoracic radiologists. So what you notice is the prevalence of lung opacity in the test set was actually significantly higher than the prevalence of lung opacity in the training set. So you had to be cognizant of that. And if you weren't, then you probably weren't going to do very well. And so, I think pulmonary embolism is a bit less subjective than lung opacity on chest radiograph. So for this competition, it didn't really seem to matter, but always an important consideration.
Right. It is also because we did receive some criticism from the pneumonia challenge, so that when we set up the pulmonary embolism challenge, that we did make sure that we have similar distribution of positive and negative cases, both for the training and test set, and similar percentage of cases from each of the contributing sites. And also when the annotators were annotating, they did not know if they were annotating the training or the test data. So they were doing all the annotation at once, and we did the split sort of in the background. So I think that probably helped to have similar data in both the training and the test sets.
Yeah, definitely.
Yeah.
Yeah, that's super interesting too to see the evolution of these data sets and the AI challenges over time. And I think one additional really interesting part of this data set was the inclusion of QA annotation. namely noting if there were artifacts related to motion, phase of contrast, or blood flow. Many AI papers in radiology will tend to exclude images with suboptimal positioning or other types of artifacts that could hinder algorithm's performance. But I believe in this data set, those were actually kept in with the label included for a particular artifact. So I'm wondering, what was the rationale to keep these images in the data set since these images could be non-diagnostic? And on the flip side, could these artifacts actually yield some type of advantage? And again, to Ian, I'm curious if you considered this at all during your solution, or if you could see it being part of one in the future.
Yeah, so both myself and the other lead chest radiologist, Dr. Stephen Hobbs from University of Kentucky, we both felt very strongly that we should include flow artifacts and motion artifacts in the data set, because clinically we know that these artifacts can lead to false positive diagnoses, and that can lead to patients being put on anticoagulation by mistake, and they can have serious complications. So we felt that because of the clinical significance, that we should take these cases into consideration, and we should be training algorithms to not mistaken artifacts as true PE. So basically, that's why we did it, and I think that is the advantage of including known artifacts in the training and test data set, so that we can make sure that the algorithm is clinically useful.
Yeah, I couldn't agree more. I think that when I see a lot of these exclusions for various artifacts or technical peculiarities, it really hinders the clinical use of it. Because, in the real world, and Ian, you're seeing this now, images aren't perfect. There's a lot of suboptimal image quality, there's artifact, and it's just something that I think is going to be a really important obstacle to overcome for AI to really reach clinical deployment. So shifting gears towards Ian. So new to last year's PE AI Challenge was the Educational Merit Award, which was given to a winner from among the top 10 teams whose entry was deemed outstanding in the clarity, completeness, organization, and efficiency of its submitted code. And that winner was none other than Ian, who also placed second overall. So Ian, there were a lot of moving parts in your solution, which had 5 different steps that you outline in detail on the Kaggle discussion boards. For our listeners out there, can you briefly explain your solution for our readers and the rationale behind it?
Yeah, sure. So the reason my solution had so many moving parts is, one, because that's sort of been my style whenever I approach a competition nowadays, is to try and develop like complementary approaches and then ensemble them in the end. But also, this challenge is pretty complex. There are a lot of different labels at different levels of granularity. And so I felt like to really do well, you had to have a multi-pronged approach. And so at a basic level, my solution was divided into, 2 separate parts. So one focused on 2-dimensional models, and the other focused on 3-dimensional models. And the reason being is the way the competition data was labeled was that each individual slice of a CT scan had a binary label of PE or no PE. That was the only label at a slice level. Every other label was at the study level. So you had like location, like right-sided, left-sided, central, but you only knew that for the entire study. And so if a PE had, if a CT had more than one PE on either side, at a specific slice, you wouldn't necessarily know which side it was on because you only knew if there was a PE. And another point being that 2D models generally, they're larger because you can have like higher memory footprint for them because you don't have to fit like a giant 3-dimensional matrix of numbers into the network. So you can have bigger models which have better representational power. And so I always try and leverage 2D models whenever I can, even with like 3D data, because I think it tends to give better performance. And so I started out by just training a model to say is there PE or no PE in a slice. And it did pretty well. The question was, how was I going to deal with all of the 3D like study level labels? And so I looked back at the 2019 challenge for intracranial hemorrhage, and a lot of teams used sequence models, which are most commonly used in natural language processing, right? So they treated each CT scan as a sequence of slices. And so they would train a two-dimensional model and then use a sequence model to sort of treat the output of the two-dimensional model as a sequence of numbers, and then produce a prediction at the study level. And so that's what I ended up doing. So what you do is you basically get the model, the 2D model, to create like a feature vector for each slice. And then you feed each feature vector or the sequence of feature vectors for a study into a sequence model, which will then predict the study level label. And so I use the transformer, which is like the state-of-the-art architecture for natural language processing and also being used very commonly now in computer vision to generate study level labels from the sequence of 2D feature vectors. And then I did actually use three-dimensional convolutional neural networks for the specific prediction of right ventricle to left ventricle ratio, because I was just thinking like, I didn't think that a sequence model could necessarily capture what an RV-LV ratio was, because, sometimes like when you measure RV-LV ratio, it's not necessarily within a single slice, right? It depends. Sometimes the maximum diameter of the ventricles are on different slices. And so I didn't feel like a sequence model would necessarily capture that. It was more of like a three-dimensional problem, which ultimately like other top winners just use sequence models and still did very well. So I did end up using like a combination of 3D convolutional neural networks and 2D models and sequence models, just so I could try and improve the performance of each and every individual label overall, and then, ensembling all of them together to really squeeze out that extra performance, which is ultimately what gets you the win in these competitions.
That's super interesting, Ian. Thanks so much for sharing. I think it's always a pleasure to hear how your brain works with these competitions. But one of the things I think is most impressive is not just that you placed second overall, but that you documented your solution with clarity, with completeness, with organization. So I'm wondering, was that something that's always been intentional or something that you've done recently? I know that the Kaggle and the AI radiology community really appreciates it.
Yeah, so I think writing papers definitely helps, like writing papers in the past, like AI research, because that forces you to sort of try and explain things a little bit more clearly, especially because you want your work to be reproducible. And if you cannot clearly explain what you did, no one's going to be able to reproduce that. I think that's like one of the biggest motivators for me to make everything as clear as I can, because I don't want this to be like a one and done thing. I want like people to be able to build upon this work or replicate it for themselves. And I think another aspect is just the importance of educating the greater radiology community about AI. And I think having really good explanations into how we build these models and sort of the thought process behind building these models and validating them at multiple levels is really important for even people who aren't interested in radiology AI to know, because probably at some point in the near future, they're going to be dealing with the output of these algorithms in one way or another. And I think you need to have some level of understanding of, how these outputs are generated and what went into it in order to be able to use and interpret these results effectively. And so all of those things put together, I think, just sort of motivate me to try and make sure that whenever I put out a solution to a challenge or whenever I write up a paper, I'm just like deliberate about making sure that it's accessible to people who may not really understand the technical components, but then also provide enough level of detail for people who are more experienced in this domain to be able to build upon or replicate the results.
I think that's really awesome, and it's definitely a great contribution to both our field and the field of data science as a whole. As we move into the last few minutes of our time together, I want to ask both of you a question that I ask all of our guests. What are you most excited about for the next decade in radiology AI?
I'm excited that we will be able to extract more information from our images, and also at the same time, hopefully improve our work efficiency so that we can provide better patient care.
Yeah, and I'm hoping that we're going to start seeing, the results of, because I know that some AI algorithms are already being used clinically, but honestly, there's not much data in terms of like, are they improving outcomes? Are they improving efficiency? Like, how do radiologists like them? I like to see more of that, and then just sort of more research about the intersection of like AI users and like the AI algorithm itself, because like how it influences our decision making and things like that. I think, how it's going to induce some like cognitive biases as we start getting used to using these algorithms. And especially as someone who's currently a radiology resident, how it's going to be incorporated into the training of future radiologists. Because we have to learn how to read on our own, but at the same time, as AI becomes more prevalent, we're also going to have to learn how to read with the output of various AI algorithms. I think that's going to be really interesting to see how that, shapes out.
Yes, and it is also important for those of us who are older to also learn how to read with the help of AI algorithms in order to stay up to date. But I totally agree with you that residents also need to learn how to read on their own. So fortunately or unfortunately, I think all the trainees still have to learn how to detect PE on their own, to recognize artifacts, and also, be able to find tiny pulmonary nodules and things like that.
Yeah.
We're not ready to let computer do all of that for us. But interestingly, when I was trying to decide what specialty to choose when I was a fourth-year medical student, which is, I guess, 2 decades ago, exactly 20 years ago, my father told me that I shouldn't pick radiology because radiologists will be replaced by computers. And I'm happy that I stuck with my choice. And I think radiology is still an awesome field to be in.
Yeah, I completely agree, Carol. Thank you both for such a wonderful conversation and sharing your thoughts on what's coming up in the next decade in radiology AI. So, thanks again for a wonderful conversation, and I'll bring this back to Dania.
Thank you so much.
Thanks for having us.
Thank you, Carol and Ian, for a great discussion, and thank you for sharing with us more information about the RSNA 2020 PE Detection AI Challenge, as well as sharing with us your journey and how you got started in AI. To our listeners, thank you for tuning in to this podcast episode. Don't forget to rate, review, and subscribe to our Radiology AI podcast series on any of iTunes, Google Podcasts, or Spotify. Stay tuned for our next episode.